Okay, hi everyone. This is the lecture for dissociative disorders, formerly known as multiple personality disorder. There's this great book that I read a very long time ago, like 10 years ago, and it was called First Person I, and it was about a man who had multiple personality disorders. It was called that back then, but it's a great read. I would definitely recommend it if this is something that you're interested in. So, dissociative identity disorder, DID, is a severe condition in which two or more distinct identities or personality states are present in and alternately take control of an individual. The person also experiences memory loss that is too extensive to be explained by ordinary forgetfulness. DID is a disorder characterized by identity fragmentation rather than a proliferation of separate personalities. The disturbance is not due to the direct psychological effects of a substance or of a general medical condition, yet as this once rarely reported disorder has become more common, the diagnosis has become controversial. Some people believe that because DID patients are easily hypnotized, their symptoms are iatrogenic, that is, they have arisen in response to therapist suggestions. Brain imaging studies, however, have corroborated identity transitions in some patients. DID was called multiple personality disorder until 1994, when the name was changed to reflect a better understanding of the condition, namely that it is characterized by a fragmentation or splintering of identity rather than by a proliferation or growth of separate identities. DID reflects a failure to integrate various aspects of identity, memory, and consciousness in a single multidimensional self. Usually, a primary identity carries the individual's given name and is passive, dependent, guilty, and depressed. When in control, each personality state or alter may be experienced as if it has a distinct history, self-image, and identity. The alter's characteristics, including their name, reported age and gender, vocabulary, general knowledge, and predominant mood, contrast with those of the primary identity. Certain circumstances or stressors can cause a particular alter to emerge. The various identities may deny knowledge of one another, may be critical of one another, or appear to be in open conflict. So the DSM-5 Diagnostic Criteria of DID is a disruption of identity characterized by two or more distinct personality states, which may be described in some cultures as an experience of possession. I think that's so interesting that the DSM put that in there. The disruption in identity involves marked discontinuity in sense of self and sense of agency, accompanied by related alterations in affect, behavior, consciousness, memory, perception, cognition, and/or sensory motor functioning. These signs and symptoms may be observed by others or reported by the individual. I did have a case in which I had a student that was diagnosed with DID, and she did switch personalities in my office. It was fascinating, and we'll talk about it in class next week. Recurrent gaps in the recall of everyday events, important personal information, and/or traumatic events that are inconsistent with ordinary forgetting. So what that is that one identity is experiencing these events, and then when an alter comes out, when the identity switches, they have no recollection of the event. The symptoms cause clinically significant distress or impairment in school, occupational, or other areas of functioning, and is not a normal part of a broadly accepted culture or religious practice, because sometimes in different cultures, this would be accepted as normal. In children, the symptoms are better not explained by imaginary playmates or other fantasy play, so it's important in kids to make sure that this isn't just developmental. And the symptoms are not attributable to the effects of a substance or another medical condition. So epidemiology, this is a very, very, very rare disorder, only 1.5% in 12 months among U.S. adults. Across all genders, 1.6% for males and 1.4% for females, so pretty even. And the full disorder may manifest at almost every age, any age. So for those of you that share in my generalized anxiety disorder, this is one more thing we can be afraid of happening to us. Risk factors, environmental, so interpersonal, physical, and sexual abuse is associated with an increased risk of DID. Prevalence of childhood abuse and neglect, those among the disorder, is 90%. So huge, huge, huge implications for childhood abuse and neglect. Ongoing abuse, later life re-traumatization, comorbidity with mental disorders, severe medical illness, and delay in appropriate treatment are associated with a poorer prognosis. Cultures, many features of DID can be influenced by the individual's cultural background. Females present more frequently, but males may deny their symptoms and trauma histories, which can lead to elevated rates of false negative diagnosis, because as we said earlier, the prevalence is pretty even. And then very, very high risk of suicide. Over 70% of outpatients have attempted suicide. That's huge. And then PTSD is the most prevalent comorbid condition. So treatment for DID, and we'll go more into this in class, but there's two kind of roads for treatment, I guess, outpatient and inpatient. So outpatient looks like psychotherapy multiple times a week. I saw some research that said 3 to 4 times a week, including extended sessions of up to 90 minutes. So this is a lot to take on for the therapist, but also just fascinating, I think. Individual psychodynamically oriented psychotherapy, imagery and hypnotic techniques, so hypnotherapy, approaches to transference and countertransference and cognitive techniques, and then really having a great treatment team. You're not going to be doing this alone by any means. And then inpatient, that would be in a hospital, so goal-oriented strategy designed to restore the patient's functioning so that they're able to resume their outpatient treatment as fast as they can. Seclusion and physical or chemical restraints. Sometimes they need to be restraints, which is sad. But however, restrictive measures often can be avoided by carefully planning in advance for symptom management and containment strategies to help in times of crisis. And then medications for anxiety and or agitation. My guess is if you're in a hospital, there's going to be a protocol for how to treat patients with DID. So this slideshow is very fast and short, not as long as PTSD for sure. This is one of those disorders that it's really important to learn about and to know what you're looking at clinically. But if it's one that you're going to treat, it's going to take a lot of advanced training on the part of the therapist. So if this is something you're interested in, I will bring in more resources in class next week to talk about where you can go to find more information.